Assalamu alaikum. We'll start this
Alaikum.
session today. Yes, with Mrs. Brandon, 45 years, female, present with visual hallucination. Let's start with after the timer. Are you ready, Dr. Abdullah?
Inshallah. Okay.
Okay. We can see the timer, right?
Yes. Let's start.
Okay. Hello there.
Hello.
This is Dr. Mukhtar, the doctor in the clinic today. May I confirm you are Brandon?
Yes, this is me.
Yeah, you are 55 years.
Yes.
Yeah, we are here to discuss about your health issue. Is that okay for you?
Okay.
Can you tell me more about your complaint? What brought you to us today?
Yes, doctor. My problem just started about 2 months ago when I realized that I'm seeing objects. When I told my husband about that, he even didn't see what I'm seeing. Then I went to my GP. Then he referred me to you.
Okay, sorry to hear that, Mrs. Brandon. Be sure that we'll offer our maximum support for you.
Thank you, doctor.
Um, yeah, Mrs. Brandon, I will ask you further question. So it was
Mm-hmm.
started all of a sudden or gradually?
I didn't notice actually, but I think it's sudden.
Okay. Any previous attack of the same condition
No, this is my first time.
since 2 months?
Yes,
Do you think it worse day after day, progressive?
I didn't notice.
And do you think anything improve it?
No, like what?
Like sleeping well?
No, no, no,
So is any particular time for this hallucination
no,
or seeing
no, doctor. It sometimes come at the middle of the day, sometimes in the morning. There is no specific time.
any vision problem now
No,
or before?
no,
Any surgery recently?
no.
Okay. Any long-lasting disease I should be aware of?
Um, just my GP just diagnosed me with high blood pressure. I think 1 month ago.
Okay. And did he start any medication for it?
Yes, he gave me a medication called amlodipine.
Amlodipine? Okay. Are you compliant
Yeah.
with this medicine?
Yes, doctor.
What the dose exactly? 5 or 10?
5 milligram.
Did you increase the dose recently?
No,
Did you add any medication?
no.
So you're compliant to this amlodipine.
Yes, doctor.
Okay. Apart from amlodipine, did you take any other medication?
No, doctor at all.
Any over-counter medication?
No.
Sorry for this question, but help us for the to reach the diagnosis.
Mm-hmm.
Did you take any recreational drugs or party drugs?
No, no, doctor. Never.
Okay. Any sharing needles? Sorry for this
No,
question.
no,
Okay. You have any headache?
no,
Any change of your eye color, the whitish
no,
or
no,
okay? Any double vision? You see two or twice or the same thing, the thing double?
no, doctor.
Okay. Any pins and needles in your body?
No.
Any weakness?
It's sometimes, doctor, I feel that my hands become weaker than before.
Any shaking?
No.
Okay, what do you mean by weakness? You feel it like in the hand or in the arms?
Actually, when I see that what object that I used to lift it before, now it looks like more harder than before.
The movement.
Not movement. When I'm trying to lift my bag, I try
Yeah.
it very hard because become more difficult than before.
Okay. And how the hand grip? You feel any problem with hand grip?
I didn't notice actually, doctor.
Okay, when someone shake your hand, you hold his hand strongly and difficult to leave
Yes.
him.
No. It's normal.
Normal. Okay. Any
Mm.
memory problem?
No.
Any affection to your sleep mood?
No, doctor.
Any change of your mood? If any
No.
depression or okay, how's
No.
your hobby? You are practicing your hobby?
Yes, doctor. I like to draw, so nothing changed than before.
Okay, any stroke or mini stroke?
No.
Okay. Do you prefer any weather?
No.
Okay. Any change of your if you have any cough,
No.
any short of breath,
No.
any chest pain,
No.
any awareness of your heartbeat,
No.
any change of your bowel habit,
No, doctor. No.
any difficult swallowing,
No.
any feeling sick.
No.
Okay, Mrs. Brandon, do you have any change of your weight recently or before?
Yes, doctor. I have noted that just I put some weight, which was unintentional at all.
Exactly which area in your body?
I think it's more around my tummy.
Okay. And you have noticed any bruises over your skin?
Yes, doctor. I have noted that my just tummy it's become uglier, and even that's what's impressing me, doctor.
Okay, you feel a stretch mark on your tummy.
Yes.
Okay. Any bleeding from anywhere in your body?
No.
You feel thirsty?
No.
How's your water work?
It's as usual. I think not change.
Okay. Any hair fall or hair loss?
No.
Any joint pain?
No, doctor.
Any skin rash?
Skin rash? No.
Okay. Back to your weight. How is your appetite?
It's like usual, doctor. No, no. I didn't notice anything.
Any lumps or bumps in your body?
No.
Any high body temperature?
No.
Do you feel dizzy while standing from sitting?
No, doctor.
No night sweats?
No.
Do you feel tired?
No.
Any family history of same condition?
No, doctor. No.
Any travel history recently?
No.
Any recent infection or antibiotic use?
No, doctor.
Okay. Do you smoke?
Yes, doctor. I used to smoke 10 cigarettes per day for the last couple of years.
And do you drink alcohol?
Yes, doctor. Yes,
How
occasionally.
occasionally? Okay.
Mm,
Let me advise you about smoking is so harmful for your condition in general. So I can
mm,
ask you to, if you don't mind, to quit smoking because it's harmful. That
Thank you,
okay?
doctor. Okay.
Okay. What's your job?
I'm a teacher.
How is that impacting your job?
Actually, doctor, swimming coach.
Okay. And how is that
Mm.
affecting your job?
It's affect a lot, doctor, because as I told you, this marks on my tummy is impressing me, and I couldn't go to swimming or teach my student.
Sorry for that. I will try to help you in this regard. Do you drive, Mrs. Brandon?
No.
Okay. You have let me examine you if you don't mind, please.
Okay, what you want to examine?
The general look, how any surrounding.
No.
Okay, the body build, body mass index,
It's like about 35.
Okay, and obesity, central obesity.
Yes.
Okay, any obesity in this intra or interscapular
No.
fat, only in the
No.
tummy.
Yes.
Okay, let's us take the vital charts. How the blood pressure?
Blood pressure 150 over 100.
Okay, you have any allergy for any medication?
No.
Any surgery before? I asked you this question, but sorry to repeat. Any surgery?
Okay.
Any
Surgery?
surgery before? Yeah,
You asked me, doctor, and I said no.
yeah. Oh, yeah. Okay, great. Okay, blood pressure, blood sugar. Can I ask for blood sugar?
Blood sugar, yes,
My ma ko
160.
hinaay ko nung kinaka.
Okay, sorry.
160.
Okay. I offer urine dipstick for ketones.
Okay. What are you looking for? Blood,
Ketones.
blood sugar is
Protein
160.
and ketone. Okay. Okay.
Okay.
Uh, yeah, the blood pressure sitting and standing,
No difference.
normal, no change. Okay.
Hmm.
I will now examine the hand, any anemia or pallor or
No.
clubbing,
No.
any bruises,
Process, no.
any proximal myopathy.
How would you like to examine it?
Raise your shoulder up against resistance or
Positive.
stand from sitting. Positive.
Positive. Mm.
Okay. Now I will go to the neck. Any raised GVP?
No.
Okay. Any tender or muscle pain ever?
Sorry?
Any muscle pain? Muscle pain.
Muscle pain, no.
Okay. Now I will go to the eye. Any redness? Any change of the
No.
vision?
No.
Okay. The mouth or for any sores?
No.
Acanthosis nigricans at the back?
Negative.
Negative. Okay.
Mm.
Any
Sarah
gynecomastia?
embarked on her quest through dark alleys and hidden
Any gynecomastia?
She's a female doctor.
Sorry. Okay. Any sorry for because this interruption by sounds make me confused later.
It's
Okay.
okay. It's okay. It's okay.
No problem. I will examine the abdomen. Any stretch marks?
The image of her abdomen on the WhatsApp group.
Okay. So let me put the time.
Mhm.
Okay. Uh, let's resume the time. Okay. Mrs. Brandon, how is your, sorry for this question, how's your period?
I think it's become irregular recently.
Okay, in the form of more bleeding or less on the timer or timing or,
Yes, it's about timing.
okay, and did you take any medication called steroid?
No, never,
Any inhaler?
never.
Okay, any leg edema by examination?
No, no,
Okay, any change of your ring size, the hand size, and the shoe size?
no,
Okay, you're waking up at night, gasping for air.
no.
Okay, may I know your concern, Mrs. Brandon?
Yes, doctor, what's wrong with me? And how you can help me about these ugly changes in my tummy that I can go back normal to my work?
Yeah, I appreciate your concern, Mrs. Brandon. Mostly you have extra protein in your blood, and this protein called steroid, it might be related to increased activity of the gland over your kidney, And due to excess secretion of this protein, I mean steroid, you might have these symptoms. To confirm our diagnosis, we will run some investigation, some imaging and scans, and we will update you in the next meeting. Is that okay for you?
Okay, doctor.
You have any other concern?
No.
Okay, Mrs. Brandon, I can advise you to stop alcohol as well because it might affect and it might lead to your symptoms as well.
Okay.
Is that okay?
Okay.
Any other concern?
No, doctor. Thank you.
Okay, thank you. Let's. I'm done. I'm not sure,
You
but
have one.
خلاص.
Okay. Okay. So, what's your case about?
Yeah, Mrs. Brandon, 55 years, came with the complaint of visual hallucination for the last 2 months. By history, there is a positive history of weight gain, which was unintentional. However, the appetite was normal. Increase the weight more on the tummy area with the stretch mark. However, no bruises or other signs of Cushing. By
Okay.
examination, yeah, there is central obesity along with the stretch mark, high blood pressure, high blood sugar. So my finding going with the Cushing syndrome.
Syndrome.
Yes.
Okay. Did you find any other other findings?
She's alcoholic and smoker.
What about her gait?
The gait?
Hmm.
No, I didn't ask for the NSC and NS examination. Yes, I missed.
Okay.
However, there is weakness. Yes, you're right. Yeah, there is proximal myopathy, and
Yes.
it was
Okay.
positive in the examination. Yes, yes. Okay.
And what? Okay. What about any changes in her back?
I didn't examine the back, but no joint pain at all.
Did you ask her
But
about
maybe
back
no,
pain?
no, specifically no. I didn't ask about back pain. For
Okay.
osteoporosis,
Okay.
yeah, maybe there is osteoporosis. You're right.
Yes, definitely. Definitely. Okay. So what's your differential diagnosis?
Yes, my differential steroid-induced psychosis.
But again, steroid? Did you find any history
Yeah,
of
Cushing,
steroid use
Cushing,
in her
Cushing,
history?
Cushing. No, as Cushing, I mean
Okay.
Cushing syndrome, and
Yes.
due to high steroids, maybe, maybe
So
she has,
what's your first differential?
yeah, Cushing syndrome
Due to what?
or Cushing disease. Due to, yeah, adrenal adenoma.
Yes. 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 Excellent.
Okay,
So
other
what?
differential, but again, is that no Parkinson's, but I put Lewy body dementia and alcohol-induced encephalopathy, vitamin deficiency, but again, is that no other finding of neurological deficits.
Yes. Okay. So if we assume this is the Cushing syndrome, what other differential?
Yeah, Cushing disease or drug-induced due to steroid use.
Yes.
However, she is not using the steroid.
Yes. Okay. So what is your plan of management for this patient?
Yeah, starting the investigation first, general investigation, basic workup, CBC, anemia for chronic disease to roll out, anemia for chronic disease, inflammatory markers, kidney function tests, liver function tests, electrolyte, full electrolyte, and urine dipstick and urine analysis for protein.
What do you
Then
expect to
specific
find in electrolyte?
electrolyte, I could expect high sodium, low potassium.
Yes.
Okay, and specific test for the diagnosis, free urinary cortisol level, along with the dexamethasone suppression tests,
How to confirm
short
your
and long.
diagnosis?
Yeah, the short and long to confirm and to localize the pathology or the disease, either syndrome
Okay.
or disease.
Okay, how to confirm? How you are going to confirm the diagnosis?
Yeah, adrenal CT for to rule out adrenal adenoma.
Before localization, I mean how to confirm the Cushing disease or Cushing syndrome.
You mean free cortisone level in the urine?
Yes,
High?
yes.
High free
Okay.
cortisone or blood or serum cortisol level, yes.
Serum cortisone. Okay, and how to localize?
Yeah, we will start by dexamethasone low dose. We will
Okay.
inject low dose of dexamethasone. If there is suppression, so it means that if the cortisol suppressed, means that there is Cushing. Then we will inject high dose to localize the disease. I mean pituitary
Okay.
cause. If the
Yes.
LCTH decreased, means it's a disease. If not decreased, mean extra pituitary, like either paraneoplastic or due to the Cushing syndrome itself, adrenal adenoma, I mean. So
In
we
case
will
of
do
adrenal
CT.
adenoma,
Yes,
adenoma, how do you expect to find ACTH?
ACTH will be low as
Okay.
feedback.
Yes. Good. So, what is the treatment?
Treatment starting by multidisciplinary team approach, including the endocrinologist, nephrologist, cardiologist, and the GP and specialized nurse, social worker, and occupational health worker.
Okay.
Yeah, non-pharmacological counseling education about the disease and complication and the harm of smoking and alcohol should be stopped here because it could lead to pseudo-Cushing, and it's one of the differential in this patient.
How to
The
differentiate
pharmacology,
between Cushing and pseudo-Cushing?
yes, the diurnal variation of steroid on the night and daytime. In the Cushing, it will be positive, but in the pseudo-Cushing, it will not be affected. I mean, the levels will be high in both, but in the Cushing, the daytime will be high, and the nighttime also will be high. Sorry, I mix. The day and nighttime will be high in Cushing, no diurnal variation, but pseudo Cushing will be positive for diurnal variation.
Okay.
Plus, there is also glucose stress test to confirm or to rule out pseudo Cushing.
Sorry, again, what?
Glucose or stress test, glucose stress test, or
insulin. You mean
insulin.
insulin
Sorry,
stress?
yeah, insulin,
Yes.
insulin stress test. Yes.
Okay. Okay.
Okay.
And
then the pharmacological, we can give the patient if confirmed diagnosis. I mean, we can start by metyrapone or ketoconazole as inhibitor for the Cushing or for the synthesis of steroids. Metyrapone and
this in
ketoconazole.
case of
Yeah,
adrenal
pituitary
hyperplasia.
adrenal hyperplasia. And
Okay.
surgery could be one of the line of management.
Okay. Well then, Dr. Basim, now you can go to the next station.
Okay, thank you.
Well, case common, but different presentation.
No, you brought it in a different way. Yes. stressful
بس
one.
هو very common يعني Cushing آخر
Yes.
النهاية expected in every exam.
Yeah, yes, yes,
But
you're right.
as usual يعني you did very well. بس few comments
Yeah,
اللي
yeah,
هي
yes, please. I want to
yes.
hear.
Okay. الهيستوري يعني أنا بحس sometimes you go to other details. So you ask about in history, ask about traveling. I think here in this case, traveling is not that important. You
Yes,
ask about
agree.
travel. Yes, yes. And when I told you that I have muscle pain or muscle weakness, I expect to go directly to musculoskeletal system. So I gave
Yeah,
you direct symptoms about musculoskeletal system. So here the involved system is musculoskeletal. You have to ask about all symptoms of the musculoskeletal from outside to inside. Muscle layer, I mean skin layer, muscle layer, and bone layer. Skin layer اللي هي if there is any skin changes, and I mean any skin bruises, striae, or skin I mean skin rash, and then go to muscle, any muscle pain, any difficulty walking up from the chair, any difficulty open the jars, any muscle pain, any joint pain, any back pain. You have to ask it specifically about back pain, which is was this patient has a back pain, indicate that osteoporosis, and should ask about the alarming sign of back pain. And after finishing, I think you forgot female history, but you go back at the end after examination. You went back to female history. The other comment about the second concern, I gave you two concerns. First of all, you told me that when I told you that I have this ugly skin changes in my tummy, and she is a swimming coach, and you told me that you're going to help me, you didn't specify. And when you asked me about my concern, I gave you two concerns. The first concern is what's wrong with me, and the second is my second concern was how you're going to treat me or to help me in this changes in my tummy, ugly changes in my tummy, and you just ignored it. I think you got some confused, maybe due to
yeah,
this noise or something like that.
okay.
But in examination, yes, in examination. What about examination? This patient, I expect to go in detail about musculoskeletal system and neurology, but you checked about you concern about, I think, different system. You didn't find any symptoms suggest that this patient might have any cardiovascular disease, and
Yes,
I denied any shortness of breath or cardiovascular
yes,
system. But in spite of that, the main system, musculoskeletal system, and I think the eye symptom is crucial. You should do this eye movement because you reach the diagnosis. Yes, this is a Cushing due to adrenal hyperplasia or adrenal adenoma. You reach the diagnosis. So I think you should focus on the involved system, musculoskeletal system, and the eye system. This is her presentation, visual hallucination, whatever. You should check for cataract. I think you should. Yes, I think you ask
yeah,
for torch or no, but you examine for cataract, examine for eye movement. Whenever this is her concern, this is what brought her to
yes,
the
you're
hospital.
right.
Yes, you
Yes,
should examine the system that brought her to the hospital, whatever, musculoskeletal and eye. If she came with visual hallucination, you check the eyes for Ballard, for cataract, for eye movement, and all the eye examination. And then go to neurology system, and especially this has abduction weakness, muscle weakness in abduction, which in her gait you will find waddling gait, right? And this is a characteristic for Cushing. Sorry. Just so to wrap up the case, yes, in Cushing disease اللي هو can be found in different presentation. The common one is weight gain or headache or hand pain. But recently there is, I think, I didn't remember the center, but patient presents with visual hallucination. So in Cushing disease or Cushing syndrome, في history focus on 3 layers. Start from outside to inside. Skin layer, muscle layer, and bone layer. And 2 high blood pressure and high blood sugar. Ask about any thinning of the skin, any excessive hair in the skin, or any acne. The muscle layer ask about any muscle pain or any difficulty raising up from the chair, or any difficulty to comb your hair, or difficulty open the jars, open the door. In this case, you ask directly about proximal myopathy in form of difficulty raising from the chair, or difficulty combing or your hair, or difficulty in distal myopathy. Ask about any difficulty of open the jars or open doors. In bone layer, you have to ask about any bone pain, back pain specifically, because this patient has osteoporosis, any high blood pressure, any high blood glucose. Systemic review in CNS is very important because sometimes this could be Cushing disease. It's pituitary adenoma. You ask about headache that characterized of space-occupied lesion, and ask about mood. You already asked. Headache is very important. Vision problem is very important because most of the patient with Cushing's disease or Cushing syndrome present with cataract. Weakness or loss of sensation. In the case of respiratory system, the coughing of blood is very important because of lung disease. I mean, lung cancer may cause ectopic ACTH. In GIT, it's very important. I expect to ask me about heartburn. You ask about tummy pain and tummy distension, I think, but you did, and dysphagia, but you didn't ask me about heartburn. And you asked me about changing bowel habits. Cardiovascular system, as usual, and genitourinary, changing your work, and you already asked. Female history, you forget from the start, but you asked about it.
I remember at the end, yes.
Yes, but you insist that this patient, you asked me twice about drug history, I think, and surgical operation. You should trust. Yes, you should trust the patient in the exam.
No, it's not trust. It's like forgetting. Yeah.
Exactly.
Was it positive or no?
Yes, it's okay. Yes, in social, alcohol is very important, and as well as smoking. In examination, as the history, 3 layers. Check. Start from top. This patient presents with visual hallucinations, so you should start with eyes. Check for cataract, check for eye movement, and bring your torch. Skin layer, you examine for thinning of the skin, cancer nigricans. You did very. You asked it about it, and in the back of the neck or in the axilla. في muscle layer, you examine for proximal myopathy. Bring the torch and examine for cataract. You already asked about buffalo hump or skin back above the scapula. And for the gait, you forgot about the gait. This patient has a characteristic gait, which is waddling gait. Concern, you answer her concern. The second one is important. I think then for differential diagnosis, the first differential, I think it's more wise to bring you didn't find any symptoms suggest that this patient might have Cushing disease like headache or other symptoms of a space-occupied lesion. So in such case, the first differential could be adrenal adenoma or adrenal hyperplasia, and next Cushing disease and paraneoplastic and so on. In then investigation, which is confusing all the time. Investigation of Cushing disease ممكن نقسمها لاثنين: confirmatory and localization. Confirmatory, the most accurate overnight dexamethasone suppression test, or 24 hours urine cortisone. But the more accurate, which is overnight dexamethasone suppression test. Then for localization, then we measure ACTH. Is it high or low or undetectable? That means if ACTH dependent, like pituitary adenoma or ectopic. So we are going to measure ACTH. If very high, and we already confirmed that this patient has high cortisol level. So the next step is to measuring ACTH. If high, that means this ACTH dependent. Go for MRI brain or looking for the malignancy. If ACTH undetectable, that means either of two, either iatrogenic or adrenal hyperplasia or adenoma. So if ACTH dependent, the next step MRI brain or looking for the malignancy CT case. If undetectable ACTH, in this case, do CT abdomen with adrenal protocol. And then for localization, in case of ACTH dependent localization, we are going to do high dose DEXA suppression, high dose dexamethasone suppression test. We give 2 milligram DEXA every 6 hours for 48 hours. If cortisone suppressed more than 50% of the baseline, that means this is a pituitary problem. Okay. So regarding the treatment, as you mentioned,
if not suppressed means ectopic.
This ectopic, yes. If suppressed, this pituitary problem. Yes. Regarding the treatment, education, counsel of the patient, and medical and surgical. Medical, as you mentioned, that metarapone for adrenal hyperplasia or surgery for adenoma, and that's it.
Okay. And the surgery has a role also in this patient.
Yes, resection of the adenoma. Yes.
Yes. Okay. Thank you, Dr. Abdulmanan. A nice case with the different presentation.
Yes. Common disease is different presentation.
Yeah, common disease is different presentation. What I put in the differential Lewy body dementia and Charles-Bonnet. You remember this Charles-Bonnet syndrome?
You went so far.
Yes, yeah, I didn't mention in the differential, but it's still there because visual hallucination, Wernicke encephalopathy, alcoholic, vitamin and drug induced. But Dr. Ihda asked a question. Yeah.
You find in the history that recent diagnosis of hypertension, this should give a hint for you. Yes.
Yes, yes. Okay, question from Dr. Ihda. What can you explain relation between visual hallucination with Cushing?
This is steroid-induced psychosis.
Yeah. So
steroid-induced
Yeah.
hallucination. Yes, has internal.
Okay. As steroid causes psychosis, the psychosis also can present with hallucination.
Sorry?
Yes, okay. The steroid lead to psychosis. Steroid cause psychosis, and psychosis can be presented as hallucination.
Visual hallucination.
Yeah, psychosis.
Yes.
Okay. Any question or any comment? Yeah, Dr. Ihda, please.
Assalamu alaikum.
Walaikum assalam wa rahmatullahi.
Regarding this case, it is actual adrenal or pituitary or iatrogenic?
This is adrenal adenoma.
Adrenal adenoma.
Yes.
With increased cortisol level, so induced visual hallucination. It is right?
Yes.
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 Thank you.
Thank you, Dr. Ihda. I tried many times to find extra or external use of steroid, but he denied twice. I asked for inhaler. I asked for oral, but I'm insisting to find because this is what we are familiar with. To find is iatrogenic, and the iatrogenic most probably cause these symptoms. But to be from internal steroid is a little different, and but still one of the possible presentation. Thank you, Dr. Abdulmanan. Any other comment, any question before moving to the next scenario? Okay, thank you, Dr. Ihda. So you can see the screen, the whiteboard.
Yes.
Is it there?
Yes.
Okay. I will write for you the scenario in the chat box. Take 2 minutes, then we'll start. Mr. John.
Okay.
Again, 55 years with complaint of Erectile dysfunction. Take 2 minutes, then we'll start.
Okay.
Differential diagnosis of visual hallucination. In this case, he gave differential for the Cushing itself. Cushing as its disease, Cushing syndrome, Cushing ectopic, or iatrogenic. If you have any Parkinson or tremors, you can put Lewy body dementia, but no other CNS or neurological manifestation. That's why you can't give another differential for. I guess
It's
also cataract. Cataract can cause this because cataract, any deficiency in the vision, patient might have hallucination, especially if acute and elderly. Yes, who was talking?
Assalamualaikum. This is Dr. Sadaf.
Alaikum assalam. Yes, Dr.
Yeah,
Sadaf.
yeah. My question was that this differential diagnosis that you are telling, it's after we have decided that these visual hallucination are because of the Cushing.
Exactly,
So
exactly.
before that, because we have to establish that Cushing is causing these symptoms, so
Mhm.
few things should come in our mind that like what might be what is the etiology of visual hallucinations. So what broad like in broader category, how like which important diagnosis we should rule out in first place after we come on to the diagnosis that this is something because of the steroids.
Okay, before thinking about steroid and what I wrote in my paper and what the examiner might ask you, show me your paper if you wrote some differential, you could think about the common cause of hallucination in PACEs, visual hallucination, I mean. So what do you think? Lewy body dementia, this is one of the possible cause, especially with Parkinson. This is what I wrote. And psychosis and bipolar disorders, but it's not common in the PACEs, but this is one of the causes. Wernicke encephalopathy, vitamin deficiency, and I wrote also Charles Bonnet syndrome and drug-induced. However, in such case, the cause was steroid, so you can say that the cause of or the possible differential for Cushing itself, Cushing syndrome disease and iatrogenic one or ectopic. Is that
Okay.
clear?
Yes,
Yeah.
yes, sir.
Whenever or anytime you are writing your differential and the examiner feel that your differential is not logic or not related to the case, he might ask you, show me the paper. This is what I hear. So when they saw your paper and you can show him what you wrote, he can give you the mark on your writing. But in this patient, as the disease become discovered while taking history, you can change your differential while talking to the examiner. This is two types of examiners. Sometimes they are asking about the differential, what you have find in the examination and history, and what you wrote in your paper. Sometimes they are asking to show them the paper. And I guess by your writing initially, you can ask to rule out this possible differential while taking history. If not, try to find what you have and put it in the differential at the end and while talking to the examiner. Let's ask Dr. Rabia as neurologist if she has, is she there? Dr. Rabia, are you there? No, she left.
No,
Okay.
I'm here. You can hear me?
Okay. Thank you. Yes, we can hear you. Tell us about visual hallucination from the neurology point of view.
Tamam. Visual hallucination from outside, the first thing you said, Lewy body dementia. It's a very good differential. Secondly, late stage of Alzheimer's can present with later on with
Yes,
visual hallucination.
excellent.
Tamam.
Yes,
Third thing
I
is
agree.
Parkinson's disease. Parkinson's disease itself in the late can cause hallucinations, but the dopamine agonist, which you will take, can have the side effect of causing visual hallucinations. Tamam.
Mhm.
So these
Yes.
are the main differential of visual hallucinations. For me, I am not sure Cushing syndrome or Cushing disease due to steroid can cause visual hallucination. This is very less likely, tamam. Yani
Yeah.
it should come lower down, but because Dr. Abdullah gave you the hint of increased weight around the tummy and scar marks, and that's why we were able, and the muscle weakness, we were able to reach
Yes.
a diagnosis. Otherwise, it's
Yeah.
difficult to reach to Cushing syndrome
Yes.
with hallucinations.
Yes, you're right.
Tamam, drugs is very important. Tamam, dopamine agonist is one of the very strong side effects is visual hallucinations. Tamam,
Yes,
acute
yes.
delirium. Tamam, acute delirium can cause visual hallucination like UTI, RTIs, hyponatremias,
Especially, yeah,
hypercalcemias, in
elderly
elderly
patient, yes.
patients. Yes, but
Yeah.
it will be acute.
Yeah, it will be acute. Yes, you're right. Thank you, Dr. Rabia.
You-
Thank you. Dr. Sadaf, is that clear now?
Yes, doctor.
Did you
Now,
have the answer for your question? Okay, thank you, Dr. Sadaf.
yes, thank you very
Thank
much.
you, Dr. Rabia. Thank you, Dr. Ihda. Let's start. Dr. Abdul Manaim, are you ready? Dr. Abdul Manaim,
Hello?
ready to start?
Yes.
Okay, here we go.
Hello?
Hello.
My name is Dr. Ahmed, one of the treating doctor in clinic today. May I confirm that you are Mr. John, 45 years
Yes, I
old?
am. I am 55.
Mr.
Yes, I am.
55. Okay. Mr. John, we are here today to discuss some issues related to your health and examine you. Is it okay with you?
Yes, sure, doctor.
Can you please tell me what brought you to the hospital today?
Yes, doctor. Actually, I went to my GP for very sensitive issue, doctor, in my life.
Mhm.
I am suffering a lot because of this problem. I can't do my intimacy with my partner.
Mhm. Mhm. I'm sorry about what you have been through. I will help you as much as you can.
Yes, thank you, doctor.
Okay. Okay, Mr. John, when did it start exactly?
Actually, it was started from long time, and I
Mhm.
noticed it become more worse
Mhm.
day after day and month after month. Now it
Mhm.
became more obvious, doctor.
Okay. Is it a first time you have this problem or comes and
Yes,
go?
no, it's first.
Okay. Um, okay. May I ask you, do you have any problem with um, this erection in the morning or no?
No problem with this, doctor.
In the morning, no problem.
Yeah,
Okay. Okay. Do you have any pain anywhere in your body?
no,
Okay. Well, do you have any increase your breast size?
yes, doctor. I noticed that. Yes, it's
When did it start
being
exactly?
embarrassing now. The same duration, doctor. Almost now 4 months, but it was
Mm-hmm.
started gradually, and now
Mm-hmm.
it's so obvious. I'm trying to wear a wide and big shirt to cover it.
Mm-hmm. Mm-hmm. Okay, and discharge.
No, doctor, it's just being bigger.
Okay. Well, Mr. John. So, any muscle pain,
No,
any skin changes at all,
no,
any joint pain.
no.
Okay. Any chest pain.
Um, not not exactly, doctor, but I have, yes, with the effort, I feel some uh, pain in my chest. Yes. especially with
And shortness of
exercise.
breath. Okay.
No, only chest
Okay.
pain.
Can you please tell me what is the nature of this pain?
It's like heaviness, doctor,
Is it localized or go elsewhere?
all over my chest.
Okay. Did you okay, Mr. John, before going further, do you have any past medical illness I should be aware of?
Yeah, yes, doctor, I am diabetic
Okay. Since when?
since 20 years.
What are you taking for your diabetes?
I'm taking a medication, oral medication called metformin,
What is the dose?
500 twice.
Okay. Are you compliant to your medication?
Yes,
What is your test that covered in the previous 3 months?
it was 8.
8. Okay. Are you taking balanced diet?
No, actually, doctor, to be honest,
Mm-hmm.
no, I am not stick to the diet regime.
Okay, Mr. John, we will refer you to a dietitian to give you advice about your diet. Is it okay with you?
Okay, sure.
Do you do daily exercise?
And not daily, doctor, to be honest.
Mhm, mhm. Okay, okay. So, Mr. John, do you have any history of surgical operation?
No,
Give me your medication list apart from
yes,
this
only
metformin.
metformin and there is sildenafil.
Sildenafil. Okay. What is the dose?
1 tablet.
Okay. So, any shortness of breath?
No,
Any shortness of breath waking up from sleep?
no,
Any weather preference?
no,
Any eye changes or vision problem?
no, no,
Okay. Any mood changes?
no.
Any headache?
Yes, doctor, I have headache.
Since when?
It was on and off, but I deny and I ignore it. Recently, the headache being more annoying
Okay. What is the site exactly?
in the middle of my head, doctor.
What is the nature of this headache? It's like looks like throbbing pain or band-like pain. Tight.
No, it's like dull aching pain.
Have you noticed anything increases headache, like bending forward or coughing or sneezing?
No, doctor.
Okay. Um, okay. No visual changes at all.
In the form of sometimes, doctor, I bumping into the objects at home.
Okay, I'm sorry about that. Okay, we will refer you to occupational therapist to know how adjust this for you and give you
Okay,
landmark for your home. Okay.
thank
Okay.
you.
Well, any weakness, any part in your body,
No, doctor.
any pins or needles.
No,
Okay. Any tummy pain,
no,
tummy distension,
no.
any feeling or early fullness sensation.
Yes, doctor. I feel full after a small snack of food.
Okay. Any bowel changes? I mean, any hardening stool or constipation?
No, but I feel some flatulence, doctor.
Mm-hmm. Mm-hmm. Okay. Okay. Um, well, okay. What about your water work?
It's fruity,
Is
doctor.
it not frothy?
Mm-hmm.
Okay. Okay. Any change in amount?
No, it's the same.
Mr. John, do you feel dizzy when you change your from sitting to standing position?
No, it's not there.
Okay. So, well, do you drink alcohol?
Yes, doctor, occasionally.
Okay. And do you smoke?
Yes.
How many cigarettes per day? For how long?
10 cigarettes for the last 30 years.
Okay, Mr. John, I advise you to stop smoking because it may have a bad effect on your health, and I will refer you to smoke cessation clinic if you want.
Okay, doctor.
Okay,
Thank you.
do you have any weight changes?
No, doctor, my weight is same almost.
Okay, well, any feeling tired?
No.
Okay, can I examine you, Mr. John?
Yes, sure, doctor.
Okay, I will start with vital.
Yes, blood pressure normal, 120 over
Sitting and
80.
standing.
Same, no change.
Okay, I would like to examine for the chest, for and I would like to examine for gynecomastia by compressing the around the
Yes.
nipples.
Yeah,
Positive.
there is, yes, breast tissue, not painful, and no discharge.
Okay, eye examination. I would like to do a H-shape examination. Follow my fingers. If you see double, let me know.
No double, doctor.
Any visual field? What about visual field?
Yes, there is bitemporal hemianopia.
Okay. Well, then I would like to examine for CNS or tone power
Yes,
reflex.
no change, normal tone, normal power, normal
What,
reflex.
what about gait?
Gait is normal.
Okay. Then I would like to examine for طيب. Abdominal examination, any organomegaly.
No organomegaly, no
Okay, I would like.
palatable kidneys.
Okay. What about cardiovascular examination? Any scar in
Yes,
in his case?
no
Inspection.
scars,
Okay,
nothing.
first and second heart sound.
Yes, and normal, and the apex in place, no displacement,
Okay. First
no
and
raised
no
GDP,
murmur.
no
Okay.
murmur, no signs of heart failure.
Okay. No skin pigmentation, hyperpigmentation.
No hyperpigmentation.
Okay. So well, okay. And then examine the back if any tenderness.
No tenderness, no change of the bone.
Okay. So what's your concern, Mr. John?
Doctor, I'm so embarrassed, doctor. Do I have something serious? I have
I
this problem
highly
with my intimacy. I have problem with my breast shape. Is there something serious?
I highly appreciate your concern, Mr. John. From what you said to me, and I after examine you, you most probably have an overgrowth of gland inside your head. This called um, this called pituitary, and giving a cause secretion of protein or hormone called prolactin, given the symptoms that you have. This might cause this problem in intimacy. This cause also your vision symptoms, and what we need to do. And actually, there is another possibility which might be due to one of the long standing your high blood sugar. That what we need to do now is to do some blood test and imaging, including that scan of your brain, to confirm our diagnosis and exclude others. Then we will sit together to discuss proper plan of management, which will be in form of group of specialists, in form of man doctor, and gland doctor, eye doctor, nerve doctor, and specialized nurse. Am I
Okay.
clear so far, Mr. John?
Yes, so clear, doctor.
Okay. Do you have another concern?
Yes, doctor. Can I continue doing my job, doctor? Because I'm dependent on my taxi.
Well, okay, Mr. John. Actually, this because this is your eye symptoms, I need you to stop driving right now because this might cause your put you in danger and the life and other life in danger. But I will refer you to social worker to help you regarding this issue. Is it okay?
Yes, doctor. Thank you.
Thank you. Welcome. So, do you have another concern or something you want me to repeat?
No, doctor. Thank you.
Okay, thank you.
Let's go to the examiner. We finish before the timer. Okay, let's start. Present your case.
This about 55 years old male with a background of type 2 diabetes, which is uncontrolled, presented complaint of erectile dysfunction. Apart from that, he has vision eye symptoms, vision problem, pumping on the side. And apart from that, he has gynecomastia. And apart from that, he has chest pain and frothy urine. On examination, my findings is he has bitemporal hemorrhagia, he has gynecomastia, he has gynecomastia and bitemporal hemorrhagia. This symptom suggestive of prolactinoma.
Excellent. So what's your differential?
My first differential diagnosis is prolactinoma. Second differential diagnosis is autonomic neuropathy due to diabetes. Third differential is hemochromatosis, but again, is that there is no other symptom suggestive of hemochromatosis.
Okay. And how you investigate this patient?
Okay, I will start with general investigation, CB complete blood count, renal function test, and urine for TB stick, and electrolyte. And I would like to do liver function test and inflammatory markers. I would like to do brain MRI and hemoglobin A1C and check. I would like to do ECG, echocardiography, and hormone profile, including prolactin and testosterone, and okay, that's it.
Gonadotrophic level.
Gonadotrophic, yes.
FSH, LH.
And LH, yes.
Yes, okay. What you suspect the prolactin level will be?
More than 10,000.
10,000 or 4,000? I guess it was 4,000. It's a significant high. Okay, let's say significant high. Okay.
Okay.
And what do you think the chest pain is related?
I think it's related to macroscopic complication of diabetes.
Excellent. Coronary artery disease.
Coronary artery disease, macrovascular, I mean.
Perfect. Okay. How to manage this patient?
Okay, education and counsel of the patient about his disease, and then about renal pharmacological. Pharmacological, we can give him dopamine agonist, like bromocriptine. But in this case, since he has after confirmed that is macroadenoma or microadenoma, and this patient has eye symptoms, so I will go for transphenoidal, surgical treatment.
Yes, the option of surgical treatment either
Transphenoidal hyposphincterectomy and
or transcranial.
Yes, transcranial.
Okay. And What after surgery you can give? Hello?
Yes.
You
I
can
mean,
give any medication, yeah, for recurrence.
I'm not sure actually. I don't know.
Dopamine agonist, as you said, and
Okay.
sometimes they are
For
giving
for
radiation
recurrence
or
or for treatment?
both.
You said for
If recurrence
yeah.
and
Mm.
or
Regress
residual,
regress the
yes,
size.
yes, yeah. Also, radiation
Yeah.
can affect or can be used.
Okay.
Okay.
Okay. Okay.
Let's. What else? So you put in the differential hemochromatosis, right?
Yes. Can
So
cause diabetes, can cause
uh-huh,
can cause erectile dysfunction, and can cause gynecomastia.
yeah, as in infiltration, you mean? Okay.
Yes.
Do you think is it related to drug induced? I mean,
Regarding his erectile dysfunction,
yes.
he's only on metformin.
Yeah, so it's not related to drug, but
Yes.
if some medication can cause like
Yes,
aldosterone
erectile.
can cause
Okay. Yes.
erectile
Gynecomastia.
and also
Can cause.
gynecomastia. You can put, but he is not.
Okay.
Yes.
Yes.
Okay. Yes, you're done. Time is up.
Okay.
You got the case. Well done, Dr. Abdul Minan. Let's
Thank you.
speak about the case and the performance. Perfect. I think no comment. You finished before the time, and you were target in the examination. You were target in the history. What you miss only here, the nature of erectile dysfunction, to start or to maintain, because it will be different. To start mean that it's something related to hormone, but to maintain maybe autonomic, as you suspect in this patient. You got it.
Okay. Okay.
Okay, and there is what's called psychological, and psychological you roll it out by the early
Morning
morning, as you
erection.
said.
Yes.
Yeah,
Yes.
or morning's erection, yes. Okay, the psychological will not have morning erection, but in our case, it's normal to have morning erection. Okay, so onset course duration, when it started and progressive, and you target the question by the breast size to have the gynecomastia, and the gynecomastia will be positive in this patient, and mostly you know the reason behind this gynecomastia. It was the prolactinoma. You ask target question also about the headache, CNS symptoms, the headache, and the alarming for the headache, and the vision affection was positive for bitemporal hemorrhagia. But you forget to ask about driving. It's very important in this patient for the
Yes.
welfare.
Yes.
Yeah.
Yes.
As I said yesterday, make them as package. Do you smoke? Do you drive? Do you drink alcohol? Do you drive? And the job. Do you smoke? Do you drink alcohol? Do you drive in certain cases? And the job. By this way, you will never forget any of them. Okay?
Okay.
Then the other CNS, like weakness, pins and needles, you ask, but very important, the scale of headache. You missed that. You didn't ask what the scale, if I give you 0 to 10, any pain, not only headache. You can ask about this question. Okay? And in case you have severe headache, you can offer me painkiller. The other system, yeah, the other target question you ask, any long-lasting disease. And from this question, you got the diabetes, and the diabetes as complication can lead to autonomic neuropathy and impotence. This is second differential. Then you ask about the duration of the diabetes, the medication I'm taking for diabetes, which was metformin. Are you compliant? Did you add any medication? If there is insulin, you will ask about the injection areas or injection skin parts. It's very important to know if the patient is under the proper effect of insulin. You ask what question about exercise, about my diet, and you refer me immediately to the dietitian. Then after the medical history, any surgical, any allergy to any medication, then the quick system review. I like your quick system review. Any chest pain, short of breath, and the chest pain here, as you said, it was angina, anginal pain, and this pain on exercise. It's related to coronary artery disease, as you said, and macrovascular change of the coronaries. Then the endocrine for any weather preference, GI. You found also I have a change in the GI in the form of early satiety, gastropathy, and some bowel change like constipation, also related to autonomic neuropathy. The genitourinary for polythiness of the urine, joint pain, and skin rash. The last system to be asked. Family history. I think you didn't ask me about family history. What importance of family history in this patient? What do you think?
Regarding actually when found
one
that
of your
patient has
differential.
Klinefelter.
Yeah, this is chromosomal. Okay, Klinefelter if chromosomally affection, yes. But in this patient, you mentioned hemochromatosis, so you can find some positive family history of hemochromatosis as autosomal recessive. Yes. Okay. You didn't ask about HIV, any question about HIV or risky for HIV. However, it's still important because infection also can, HIV can lead to autonomic neuropathy. Even one single question, you have partner, you have any casual relationships like that. Okay?
Okay.
The examination was started by vitals, how is the blood pressure sitting and standing for autonomic neuropathy. Blood sugar, you didn't ask me. Even glucometer offer. Can you check please blood sugar, glucometer? Yes, it will show you high blood sugar. And urine dipstick offer urine dipstick for the diabetes and for proteinuria. Pulse rate and regularity, equality for the pulse. This is for the vital. The general look of the patient for gynecomastia. You examined gynecomastia perfectly. First, by inspection, is it bilateral or unilateral? Any redness, any mass, and any discharge. Then you feel any pain with it, any soft tissue, any swelling, and lymph node you can offer also for axillary or cervical. Apart from this, for the heart symptoms, you can ask for, as you did, murmur and S1, S2, and the apex in displacement. This is for the cardiovascular. Then totally, you didn't even offer examination of external genitalia. As an only offer, you just teach me how to examine the complaint in the previous case, the eye. Yes, you didn't examine for the genitalia. Even the examiner would say no need, don't do it. But you will ask it and you offer it. I offer examining the genitalia. Why? Because of loss of hair, maybe the shape, maybe undescended testes, maybe you will think about some chromosomal disease like Klinefelter, as you said. Okay. This is for our case today. So the differential, starting by the main presentation, prolactinoma, then diabetes as impotence or autonomic neuropathy, And I don't think hemochromatosis will be in this patient because they have no family history. So also no drug history. So I can't say also, I cannot say drug induced. I think these two differential will meeting the case, diabetes as impotence, autonomic neuropathy, and our case prolactinoma. You can say psychological, it's still there because it's common cause. But hemochromatosis, as long as no family history and no signs of hemochromatosis like tanning of the skin and so on, so you can't mention them. So let's repeat the differential. Either prolactinoma, which is the case here, diabetes impotence, and psychological. Psychological you can put because you can't rule out it. Okay. The investigation for the general investigation as you did, and specific investigation for the disease, prolactin level, significantly high prolactin, FSH and LH and testosterone. I guess all will be low due to prolactin level, a high prolactin, I mean. Then hemoglobin A1C for the complication, hemoglobin A1C, or sorry, for the disease itself, sorry, for the association diabetes. The hormonal assay, the target in this patient. MRI pituitary, as energy didn't mention, it's important as well. MRI pituitary, it will show macroadenoma because the patient is have compression signs. The medication or the treatment, as you said, non-pharmacological and pharmacological, and the non-pharmacological education, counseling about disease, and for the pharmacological, dopamine agonist, and the surgery will be the definite treatment of this patient. Sometimes you can add post-surgical radiation, or for the recurrence, you can give dopamine agonist again. I guess this case was clear.
Yes.
Any question, Dr.
Thank you.
Abdullah? Any question by others? Yes. Actually, both
Thank you
cases
so
today
much.
was great and nice cases, new cases. I hope all will benefit from these cases today. Any question, any comments by others?
Can
Please.
I ask about, he said, I will refer you to the man doctor. I didn't get what is the man doctor.
Yeah,
He
men,
meaning
maybe fertility, you mean, Doctor? I didn't,
Fertility, I mean. Yes, I mean fertility.
maybe you can say the
Yeah.
sexual health clinic, sexual function clinic,
Okay.
because I
Always,
said
Doctor.
Because
Yeah.
in gynecology we said woman doctor, so I said
no,
the
no.
same as.
I'm working in sexual health clinic, so I know for erectile dysfunction
Okay.
there is a sexual function clinic. We can refer him to that. And the other thing at the beginning, this patient, maybe he will become embarrassed and doesn't want to say anything. So we can
Yes.
assure him at the beginning, we'll tell him, I just want to assure you that everything is confidential, even for your GP,
Yes.
unless you give us the permission or there is something cause harm to yourself or to the others. So this is the confidentiality, that everything will be confidential here, unless he gives us the permission or there is something that cause harm for himself or to the others. So the patient from the beginning will know that everything is confidential, so he can open up. At any case that the patient will be embarrassed of open up or afraid of anything will be disclosed to other people. So we can say this phrase at the beginning.
Thank you, Dr. Sarah.
Okay,
Always you are
thank you so
giving
much.
golden advice. Actually, yeah, from the real UK.
I'm
You are in
working,
UK,
yes, I'm
right?
working in
Yeah.
the HIV and sexual health clinic. So this is everyday scenario with me.
Okay, good.
Yes, okay.
Yeah. So, andrologist. You are
Andrew,
the
this
one
is
who.
No,
considered
I think
jargon, I think.
yes, this
No,
is the
no.
jargon. Only the sexual
This is
function.
jargon.
Yes,
Sexual,
sexual function
yeah.
clinic, he will know what is mean by sexual function clinic.
Yes, yes, I agree with Dr. Sarah. Thank you, Dr. Sarah. I
Thank you.
hope you will have a case for us one day from real life because
Yes, for HIV, I can have some information about the HIV, but apart of that, still I'm not studying well for the pieces.
it's okay. Take your time.
Yes.
One day you'll be perfect and professional,
Okay,
and
thank
you can practice with us as well.
Okay, thank you so much.
Thank you, Dr. Sarah.
Okay.
Always comment on our performance from the point of view from UK, from the
Hello?
UK point of view. Yes,
But I think if you are your exam in other part from the UK
yeah,
will
overseas.
be the pieces is easy. But here in the UK, they are bringing a lot of complicated
Tough.
cases.
Yeah,
They are not
tough.
bringing stable. They should bring stable patient, but they are bringing, especially in generality, a lot of complicated cases, vestibular syndrome, because they have here a lot of complicated cases, not the same things. I
In the
think
overseas.
that's why
Yeah.
I'm thinking this is regarding the scenario. It will be here more difficult and
No
tough.
problem, Dr. Sarah. If we solve the difficult scenarios, we can solve the easy scenario.
Yes, yes. I
So
hope.
yeah, if you have interesting case one day, you can do it with us. No problem.
Okay.
Thank you for
Okay.
for sharing us.
Thank you.
Thanks a lot, Dr. Sarah. Any question, any concern, any comment from others?
Hey, Dr. Basim, how are you?
Alan, Dr. Abdullah or Dr. Hassanin?
Dr. Basim, I have a
Hassanin,
query
yes.
regarding hemochromatosis in female. I listened to the sessions presented by one of the mentor, and actually I didn't attend the sessions,
Yes.
but I
Yeah.
read the scenario. The session was يعني yesterday. Read the scenario
Yes,
that
yes.
that the patient was female, and I read just now the recording of the session, and the diagnosis was hemochromatosis. So I wonder, is يعني hemochromatosis symptomatic in the female? I think I read in some text that the hemochromatosis it can affect the female because it is autosomal recessive. But the symptoms and the whole these typical features يعني didn't appear in the female. So what's
Yeah, you mean
your
for the menstruation,
comment?
right?
Yes,
Due to
okay.
menstruation,
Regarding the
yeah,
menstruation, loss of iron in the
yeah,
bleeding. So what do you
yeah.
think?
But if you remember, the case was postmenopausal, so no more menstruation, and that's why she was symptomatic. She was postmenopausal. I remember this. You got it?
I didn't attend the يعني session,
No, I
but
attended. I attended. Yeah, the question
uh-huh.
for the period, the answer was yes. She already lost her period. Uh, I guess so. That's why the symptoms start to appear late.
But okay, but she became amenorrhea because of the hemochromatosis, I
Yeah,
think.
infiltration.
So
Yeah.
infiltration. So the female is losing iron in her period. So how these iron accumulate in her gonads and causing this?
Yeah. Yes.
Actually, we need
Because of
review.
amenorrhea,
Mhm.
no more period and no more loss of blood. That's why the iron become more like
You mean
she's not
uh-huh.
losing.
Okay.
Yes, because before,
Okay.
yeah, with the period, the loss of blood lead to I guess no symptoms. But now, due to this amenorrhea,
Mhm.
so the iron load will be higher because she's not
Actually,
losing blood.
okay. يعني you mean the amenorrhea, it is physiological,
Yes,
not the complication of the hemochromatosis. And the
physiological.
hemochromatosis feature, eh, and the hemochromatosis feature develop after physiological amenorrhea.
Yeah, yes, exactly. Either due to
Mhm.
infiltration or menopausal, maybe menopausal, but maybe in this case particularly was due to the infiltration. That's why she lost the period.
To be
And
honest with you,
yeah,
uh, يعني I still afraid to put hemochromatosis in the at least the third differential in any female.
okay, but maybe in
يعني
younger
the idea,
patient or younger female, yes,
the idea is frustrating, I think, because I read in many texts that the uh, يعني even in the MRCB polls of the MCQ and these knowledge books, it said that the hemochromatosis in the female much less common than in male because
yes,
you know the periods. So it is
yeah,
very rare complication to occur in the worldwide, uh, and it is
but
also rare
still,
in the female. But still,
yeah,
okay, still everything
yeah,
is can occur. Okay, but so I am afraid to put it at least in the one or two differential. Well,
yeah,
that's my question. Uh,
yeah. And the answer now, I think, makes sense. The period is lost due to amenorrhea or menopause or whatever. So the
mhm.
blood and the iron will be lost in the periods is not
Yes, yes.
lost in these cases. So
Mhm,
yeah, we can accept it as a differential.
mhm,
But the idea from the case, I heard this session online and
mhm.
live. The idea he want to give differential from hepatocellular or cholestatic. This is
Mhm.
his aim of the case. The differential for the cholestatic pictures different than the differential of hepatocellular one. So
Yes.
in yesterday case it was hepatocellular. So what do you think? It's hemochromatosis. You can think about autoimmune hepatitis, and he gave also another differential as I think hemochromatosis and autoimmune hepatitis. I think yes, non-alcoholic fatty liver disease.
Fatty liver disease. No.
Yeah. So the case was for teaching purpose, I guess, and he gave it to differentiate between cholestatic and hepatocellular.
So, يعني I am asking يعني this is a question for you in the basis in the
Yeah.
يعني real exam. What about the hemochromatosis in female? I put it second differential, third differential.
Yes,
I
you're right. You
actually
put it at the first differential in male, more wise, but still there.
mhm.
According to the
Okay, okay.
finding and according to the history, roll out and roll in.
Yes,
Okay. I hope it's clear now.
thank you.
Thank you, Dr. Hassanin. Any question regarding this case, Dr. Hassanin, or any comment?
Actually, I didn't attend the whole يعني
Okay,
session because of my
no
work.
problem. No problem.
It is nice. Thank you. It is nice. يعني scenario regarding hemochromatosis and in the erectile dysfunction. But I am wondering about the gold standard test for diagnosis. It is liver biopsy or يعني genetic study.
You mean for yesterday case again? Still you are
No, 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 no,
confined
no.
for today?
يعني إيه for today.
No,
It
no.
is a
No
question.
one. No, no. It wasn't hemochromatosis at all. Our
Uh-huh.
case today
Okay,
wasn't hemochromatosis.
okay,
Yeah,
okay, okay, okay.
you mixed the cases.
No, no. I
Yeah.
يعني
By
some
the
mixing
by the way,
concept.
in the past test,
Yes.
they are not
Uh,
they are not putting liver biopsy as diagnostic hemochromatosis.
Yes, yes.
I agree
Thank you,
for
thank you,
this. Yeah,
thank you, doctor.
I agree with this idea. They are not putting liver biopsy for hemochromatosis. They can do HFE gene rather than doing liver biopsy because liver biopsy is too much invasive test.
Yes, may avoid liver. Thank you.
Yeah,
That's okay. Yes.
yeah,
Thank you very
but you
much.
put it in the plan. You can do it. Still, you can do it. You put it in the plan. You can
Uh-huh.
put it in the management plan or the investigation, but
Yes.
it's not the diagnostic one. Yes.
Yes. If you have يعني typical features of hemochromatosis and the genetic study unavailable or equivocal. So I go to the liver biopsy.
Excellent. Yes, excellent. Yes.
Yes.
Okay,
Thank you
I
very
agree
much.
for that. Thank you to Dr. Hassan. And yeah, thank you. Any other comment from others? Any other comment? Any question? Okay, I guess Dr. Nusayba didn't join yet. Okay, any question for any point, for any case, for any debate? Anyone interested for communication scenario? Or you want to finish early today? Tomorrow is Friday, our off day. Dr. Ihda, you're raising your hand since before or new? Okay, any question related to the bases? Why all quiet? Sleeping or satisfied with two cases? Clear. Okay. If no question and no comment and no interesting case and no communication participant, we can enjoy our weekend with more Friday off and we'll meet on Saturday. Are you agree? All? Thanks all for very nice and
Okay.
thanks, Doctor. Yes. Agree, Dr. Abdullah, right? Agree with me.
Agree, yes. Yes.
Because also I am morning duty tomorrow.
It's okay.
So yeah, so let's sleep early. Thank you all.
Okay.
I will end the
Thank you, Dr.
recording.
Faisal.
Yeah, agree. Okay, agree for the weekend, inshallah. Okay, happy weekend, inshallah. We'll meet on Saturday with new cases and new participants. I hope. Assalamu alaikum wa rahmatullahi wa barakatuh. Good night and good night.